want to thank Jody and Mended Little Hearts for inviting me here today. I've sat since yesterday listening to a lot of the talks and giving presentations. I know a couple of speakers have asked you who is a current parent or a CHD survivors. I'm wondering, are there any siblings in the crowd? We haven't asked that question. One. Well, I'm the other sibling. You know, I've been doing this for 15 years at CDC, and I never thought that my career would focus in this area, but it's funny how things become personal. And today I wanted to give you a little bit about some of the numbers that you sometimes see. Again, this is going to be similar to that previous talk where his charge was on innovations, and my charge was facts and statistics. So what numbers do you pick? You know, what do you use? And so I'm going to go ahead and focus on sort of my part of the world and explain to you some of the numbers that you see from public health, from CDC. I'm not going to cover all the numbers, but at least this will give you an idea of some of the numbers and how we get that and what we have to do to get some of the numbers to try to get a really good picture of what's happening in the US. So one of the ways we try to frame the data is that even though individual conditions that we look at can be rare, but collectively they are common, costly, and critical. This is kind of how we try to approach some of this. So where do we get some of that? Why do we say they're common? And when we look at congenital heart defects, you know, we say every 15 minutes a baby's born with a heart defect. Or when we look at some of the cost data collectively, we say in 1 year, it exceeds $5.6 billion just in 1 year for care of children from age 0 to 20. And then the number of people living with a CHD. So where do we get some of that? You know, these numbers are pretty global, but it boils down to people like Tegan. When he was 4 days old, his mom found out that the happy, big, baby boy, healthy little kid that she thought she could take home all of a sudden had some problems. And it turned out he had hypoplastic left heart. And then, you know, 3 days later, he was in for his first of his 3 operations. And he's 7 now, but he continues to have a lot of lifelong issues. And he represents that 1 in 100 that we talk about. So how do we know these numbers? Where do we get it? What do they really mean? And each one of you guys sitting here have a story, and I've heard some of the stories, and they are really amazing and really powerful. And when I think about the individual numbers, I think about it as sort of a patchwork. So you've got your story, and then we piece it with all the other stories. What is that collective picture? What's that big picture? And that's kind of, hopefully, if you don't get anything else from my talk today, that's going to be sort of the view that you get is how do we get that bigger picture? I know many of you are at different stages of thinking about this, and you know, they're different stages, but what we want to know is, in the US, how can we get at those numbers? And so one of the most really exciting projects that we've been doing, and I think a number of you guys have been involved, is that we know that 1 in 4 babies with a congenital heart defect has a critical condition. And it's been really exciting to see some of the work that's been happening. I mean, look at this power. I call it the power of the parents, as well as working with public health and medical professionals. In just 2 years, look at how the states have lit up in terms of the screening that's happening now. And we just published an MMWR article last week, I believe, that highlight the changes in legislation and in regulations and in the different rules that are now, babies are being screened for critical congenital heart defects. So part of us, in terms of the data, what we try to do is look at the lifespan. So how do we track across the lifespan? And I can tell you, I'm not going to have all the answers. I'm going to be able to give you some numbers, but there's a lot of work that we still need to do. But thinking about where we are today, I mean, it's amazing how much better in terms of some of the numbers. We're getting a better picture. It's still not a complete picture, but we're moving along in that spectrum. And so, as I said earlier, this talk's going to be a little different because you kind of have to think about sort of this patchwork of all the different stories. And what we want to do is we want to be able to monitor all that, not just the voices that we hear, not just the patients we see, but within the population, within your state, within your community, and across the US. You know, how do we get some of these numbers? How do we have that more global picture? And so one of the ways we do that is through population-based tracking. So we have these ongoing data collection. We have data collectors who go out and look at medical records. They also look at discharge data set, tons of different types of data to try to give us that complete picture. But to me, that's not what's really powerful. What's really powerful is what we do with that data. What does that tell us? What kind of story? What can we do with it? What kind of research can we do? How can we help? How can we intervene? And what are some services that we can do to provide the families? And when we kind of think about it from our approach, then the first thing is really that surveillance, that data. How do we develop these surveillance systems to be able to get good data? And then what kind of research do we do to look at risk factors and possible causes? And then what can we do to help the families and intervene with programs? And so this is a map of the states. The blue ones are the ones that are collecting babies born with birth defects, and a lot of them include congenital heart defects because that's the most common group. And at CDC, we work with all of them, but we specifically fund 14 to try to collect timely and more accurate data, and then to really drive and do something with that information. And a lot of the work we do, so the challenge for us is really what we want to know is within a community. We know there are pockets, we know there are gaps. So where are they? Are there racial, ethnic differences? Are there survival differences? And you'll see different spectrum, but I think what we try to do is try to look at, can we identify all the cases within that population, within your state, or within a region, and then look at that bigger picture, not just the kids who get surgery, but the ones who can't because of whatever reason. What was their outcome? What happened? What's their survival? Does living in certain communities, like the socioeconomic status, impact that child? And we know it does. Based on the data we're looking at, it's pretty clear. And then what about some trends? Some of our systems have been in operation for a decade, 2, 3. Can we look at that and can we find out? Obviously from the clinical data, there are a lot of advances and we can see it, but what we're interested in is looking at all the babies born with it, being able to follow up with that and seeing what is happening with that. And so we've been able to publish a number of papers trying to think about that system. And this is, again, another story. This is William with a tragedy of Fallot. And one of our biggest gaps right now is trying to figure out how many children and adults are living with a heart disease in the US with a congenital condition. And I have to tell you, this number, this is something we use now, but this is not a US number. This is a Canadian number. We are trying to see if we can get better data looking at the US population and not just Canada. Part of the challenge is that we're really good at trying to identify all the babies born with a congenital heart defect and then being able to track it. But the challenge is, as they age, especially for some of these conditions, if they don't get services or if they are not in the system, there's no way for us to capture. There's not a unified way for us to be able to do that. And so the best we can do right now is estimate. But we're trying to come up with different strategies on how to get better numbers. So the next part I wanted to cover is then once we have some of these data, another big question unknown for us is thinking about the different causes. I don't think this is new for you guys. We all know that most causes of birth, we do not know the causes of most birth defects. We really have this small sliver of genetic, some environmental. What we really think is it's really a combination of the two. You might have a genetic susceptibility, and then there might be a trigger, and then perhaps that's, but we don't know. So this is us trying to figure out what's going on. How do we decrease this red section of this graph? And so one of the things we've been doing for a while now is to sort of build this. So if you look at the highlighted programs, what we've been doing for the last 15, 20 years is trying to build the infrastructure. So again, thinking back to that population-based data, trying to get all the babies born with these conditions, and then inviting the families to join us to try to figure out and look at some of these risk factors. And so at the heart of this is us interviewing moms, and it's a very long questionnaire. I mean, almost anything you can think of, medication, exercise, diet, it's all in that questionnaire. And then we also collect cheek cells. And the MBDPS part of the study, we concluded in 2011 with the data collection, but we're still analyzing that. We have over 12,000 families with a congenital heart defect, and the entire study has over 40,000 because we're looking at many of the major birth defects that do not have known risk factors. So for example, Down syndrome is not in the study because we obviously know the cause for that. But for many of the other ones, we don't know. So that's been really the emphasis and then now we're moving on to BD steps, trying to figure out what do we learn from the previous studies? What are some areas that we can really focus on? And again, this is thinking about the best approach with the population-based, trying to get after, and so why would we use that kind of approach? Part of the challenge is selection bias. We don't want that to bias. We don't want to just handpick certain individuals. What we want to be able to do is have the best type of picture that we can get, and hopefully the results will be more generalizable. And again, a lot of these systems are in place, so really just trying to build on that infrastructure and then tapping into the researchers and the experts we have in place to help us analyze that data set. So if you really are looking at risk factors for a lot of these congenital conditions, there are quite a bit of number of publications in this area. But basically, there are some areas that it boils down to. So we've really emphasized looking at obesity, diabetes, smoking, medications. For example, with diabetes, if a mom has diabetes before pregnant, she has a 4 times increased chance of having a child with congenital heart defects. So before anyone tells me anything else, what I want to make sure I get home to you guys today is that a lot of this research that we're doing are risk factors. Many of you guys are here because you define odds. It does not mean that if you were diabetic and you didn't control your blood glucose, that was because. I think part of this is us trying to get a better picture collectively. Again, that patchwork of individuals. Just because it might affect a certain type of population doesn't mean it's going to affect every single one. And there's no certainty in life. And that's the same thing with research and data. And so for us, with this quest for trying to, we want to know why. We want to decrease that red box. And so these are some of the ways that we're actually trying to get at it. And then the other area that's we're doing a lot of research is the care received, health outcomes or costs, and education. That has been covered quite a bit in this conference. But being able to link those big type of data sets to see collectively if CHDs are really going to be making that much of a difference. So this is one of the research I wanted to show you, is that when you look at hospitalization, less than 4% were attributed to CHD, and yet, if you look at the hospital costs, it's greater than 15%. And so this is power, this is knowledge, being able to look at some of these data sets and tell us collectively what's happening with the population. Again, there's a lot of interest also in education. What we're trying to do now is to be able to link some of our data with the education. This was a brief look. I think this paper is going to be coming out very soon, showing that the children with CHDs are receiving special education at a higher rate than those without major birth defects. And that we're seeing similar between those with critical and non-critical congenital heart defects. Another area that's a lot of interest is understanding long-term outcomes. I think this is a theme that I keep hearing, is that with so many survivors, and this is also another area that we really don't have a lot of answers, so trying to figure out what are some ways that we can get at some of these. So how can we better link some of these data sets to be able to figure out at a population for the US what's happening with a lot of the CHD survivors. And so I'm going to wrap up my presentation with the last segment on prevention and intervention. So once we're able to have some of this information, then what do we do with it? So as I said, the power is in not just collecting the data, but what we do with it. In some of our programs, the 14 states that I fund, one of the things we do is when you think about it at we're able to identify a lot of these babies born with pretty major severe conditions. And so are they being linked to the services that are in the community? And if they're not, why or why not? So trying to work with other public health programs to be able to address some of that. So that's part of the funding that we support at CDC with the 14 states. And then we do try to raise awareness and address some of the prevention issues. So earlier when we were talking about when you look at the embryology and fetal development, a lot of the fetal development happens in those first few weeks of pregnancy, oftentimes before you're going to know that you're pregnant. And we know that 50% of the women have unplanned pregnancy. So what do we do? You know, how do we get the moms to be as healthy as possible, to give her to have us have a better chance? And so there's some things that we're doing with alcohol, again, folic acid, safer medication use, and then thinking about just general preconceptional health campaigns. So these were some tweets that we included in January, and I was really excited that many of our programs and a lot of families participated in trying to raise awareness about these issues. And I don't know how many of you guys participated in that the little hat, big hearts, but the Mended Little Heart did that. And as a knitter, I was so excited to see it. And so we got a bunch of our researchers and scientists together. I was very amazed at how many people were willing to learn how to knit. So we were able to knit over 110 hats. And then Dr. Matt Oster brought it to the Sibley Heart Center, so we were able to do that. So I applaud you guys for doing activities like this, because I love the way it just raises awareness about the issues that we're so passionate about. And I wouldn't be up here talking about some of the work we do without a team of public health and medical professionals. We really do try to merge the health researchers, the epidemiologists, along with our clinical geneticists, our pediatric cardiologists, our pediatricians, OB. I mean, we pull in a lot of different types of specialists to be able to address some of these issues and to get the data. And thank you again for inviting me, and it's been great to be with you guys the last 2 days.